So what is a learning health system? It's about using our data to improve what we do in the healthcare system. It's clearly a socio-technical system. So it has to have organisational and social aspects, but it's also got technical aspects. This is truly interdisciplinary work. So when we talk about a learning system, then it's about trying to understand process and improve performance and the effectiveness of what we're trying to do. It's about new terms reflecting new distinctions and priorities. So these are the outcomes of a learning system. The technology has to be an enabler. Anything we must do must be understood as a progress, not a project or a programme, but it must exist outside of the usual ways of doing things. This must be a long-term aim that we have, not the government has, that we have and we own. It must be collaboration.
What we wanted to do was develop a palliative care plan that could be shared across the system, and something that was practical, real, and could be scaled up across the North East and North Cumbria. What this project is really about is the people in that bottom circle, which are patients, their families, the professionals around them, and the supports around them. And we produced Deciding Right, which is 3 standardised documents. We also produced standardised data that as clinicians we'd start to use. So education and skills was really, really important, because it's no good just delivering one set of education. Finally comes in interoperability. So you can't put a solution into a system or a set of systems without having all of those steps already there in place. Because we had standardisation, it meant when we're looking at this project, we're already in quite a strong place. So we actually have a set of palliative care patients that we recognise in primary care that we could identify we wanted to share information about. And pretty common, straightforward things we're looking for: 24/7 access, no duplication, access by at the point of time, and knowing about changes that happened at the point of time as well. We have been working really closely with Northumbria University to do a formal evaluation of this, and they've been looking at the implications of this kind of system. We've been doing a lot of action learning in this project. We're learning as we're going, and this needs to be captured if this is to be expanded and rolled out across the area. On average, for a palliative care patient who in the last 12 months of life, they can have up to 3 inappropriate admissions. Each of those have a substantial cost associated of about £4,500. And if we can avoid just one of those, not least for the patients, the impact on our systems is huge. One of the great things that's come out of this is getting and sharing and being a constructive friend about the data that's collected.
The project aim of Silver is to explore the barriers and facilitate us to link in health and social care data in families with children involved in local authority help services, to meet the needs of families with a range of needs that need to be met by a range of services working together, not in isolation. What is quite often missing from the information that early help services have is health information. And I think it's fair to say it's recognised that it would add a lot of value to the support that early help services provide. When we were developing Silver, we recognised that there was a need to facilitate having a consent portal easily interpreted by non-health professionals. So this led on to the second phase of the project, which involved colleagues from Open Lab leading in work on user research. What was found is that the consent model needed to be clear, explicit, that consent should be resought at different periods throughout that journey, and that practitioners should be explicit with families about who had access to their health data and what it would actually be used for. And lastly, and most recently, the third phase of the project, Silver has been developed. We tested that quite recently with a small group of practitioners. They found it quite easy to access, and the intention is that it aids practitioners' understanding in the needs that families have around health support at the earliest opportunity.
There are 4 different areas that have contributed to our learning health system. That's the findings from the research, the system development, the external facilitators and barriers, and the wider health and social care context.
So this work came to address needs given by the healthy new towns. Darlington and Bicester were particularly concerned about there would be a lot of new houses, and they wanted to know, particularly the GPs wanted to know, what would be the impact on their practices. So we developed an app to help them to understand what the demand was at the moment, and then to help understand what the demand might be with these new houses. So another part of the app that came from talking to the GPs was the interest in the future demand in terms of how much it would cost if they had to get locums in.
So one thing we learned early on was that there's some key things to balance here. There's learning from the past, because we already know some stuff, managing the present and creating the future. We began with, what do you need to work on, how does it work? So that's important. We start with the need in the collaboration. Start talking to the IG specialists early, understanding skills and roles that you've got to start thinking about the different roles and responsibilities. In collaborative projects, you need to project manage. There is a real need, we've learned, to get a common language and a common system in place. It's to let the system begin to have a common set of paperwork, procedures and frameworks. The trusted research environment, that becomes more and more important for each university or each organisation to potentially try and run safe havens. It'll cost a fortune, it will not work. Try and share the analytics and try and share the data sharing. Is we actually were one of the first groups of people with the IG gang to begin to try a GDPR-based information sharing agreement. The Great North Care Record going forward needs to recognise a better approach in the back office. There's some work to do to standardise. There's a responsibility on all concerned to make sure it's done right and properly project managed. What's now important is an infrastructure is built, but it's a whole system approach.
We have built a trusted brand, and we have got 2/3 of the Great North Care Record in place this year, and the remainder, the Trusted Research Environment / Pop Health platform, will follow shortly. So I think as a region, we've done something really special. Thank you, and thank you for your part in it.